Thank you, and thank you, PK, for the kind invitation. It's a great pleasure to be here again, and congrats to all the team. It's an amazing meeting. Interesting topic, especially for endovascular physician. We know that historically, the common femoral artery was treated by surgery. That was still considered the gold standard for many reasons, but in the few last years, we observe a tremendous improvement of the technology and the techniques. So now we can also treat this area with endovascular procedures. There are still some drawbacks that we have to consider. First of all, that the huge amount of calcium we see right now from the case from Leipzig. And also there are some concerns regarding the use of stent in this area, because this can compromise, the flexibility of the vessel, the patency of the stent, but also we can lose an access, because this is something that we have to consider, especially in case of young patients. Now, in terms of procedure, the first key point is how we can approach the common femoral artery. My preferred treatment modality is the contralateral side with a crossover, but we can also go retrograde from the ipsilateral superficial femoral artery. This is especially if we have a large vessel, straightforward pathway. But remember, in this case, it's mandatory to use a vascular closure device, because manual compression is not working very well, as there is not a bone where we can compress the artery. Obviously, we can also use an upper limb approach, radial, brachial, according to the position. And another option could be directly from the deep or the profunda femoral artery. In terms of treatment, one of the big problems is calcium. I know that the calcium is the big enemy, but what is generally in the common femoral artery, we have something that is like a coral leaf-like calcification protruding into the lumen. So it's very important. This came out from several studies to remove this calcium and prepare the vessel with a residual stenosis less than 25%. How we can do this one? Obviously, we can use a standard balloon, but we can also use special balloons, chocolate balloon, scoring balloon, but also IVL or atherectomy. This is a study that reports some data regarding the use of directional atherectomy. It's a retrospective evaluation of 250 patients with a mean follow-up of 31 months. And what is interesting, you can see on the right side of the screen, is the calcification. You see the outcome is completely different according to the severity of calcium. So when there is a lot of calcium, again, we must be very aggressive to maybe debulk the lesion or shock the lesion and then complete the treatment modality. However, they report a freedom from clinical-driven TLR more than 80%, with a complication rate around 10%. The use of IVL was evaluated a couple of years ago in a single center. They compare IVL plus DCB versus atherectomy plus DCB, evaluating the clinical-driven TLR with angiographic restenosis more than 50%. You can see here that after 1 year and 2 years follow-up, there is a little bit a small advantage of the atherectomy plus DCB versus IVL, but definitely this is a minimum gap. So I think both techniques can be considered valid in this condition. The treatment modality, once we have prepared the lesion, we can have different options. Obviously, we can do a standard PTA, but if you are familiar with the cauliflower study, we know that angioplasty is not performing very well in this area. So generally, we can also use a stent. If it is a simple lesion that is just involving the common femoral artery, a short single stent, balloon expandable self could be fine. If it is, the problem is that the disease is going also within the superficial femoral artery or the deep, then we have to extend the scaffolding technique into the other vessel, or in more complex situation, also kissing stent could be an option. Recently, there is some experience using the superior stent that can provide a very nice outcome. You see here, 15 patient technical success, 100%. Primary patency at 1 year, 100%. Obviously, this is a small group of patients, but they report something very interesting because you can see, according to them, the presence of the superior stent is not a barrier for future approach in the common femoral artery, because they were able to stick the vessel, navigate the stent with a 4 and 6 French introducer, and also to occlude the entry site with a closure device. So there's open the opportunity to have more opportunity treatment modalities in this area. Obviously, when we talk about stenting in the common femoral artery, there are some debates regarding the patency rate and the fracture rate, but you can see it is reported in the literature to be very low, 2.5% at 5 years. And also this is thanks to the technical improvement of the devices that are now available. This is a case that we did a couple of years ago in our department. You know, the lady with a severe claudication. We were pretty aggressive in the preparation of the vessel with a 7mm dilatation, and we treat this lesion with a bioabsorbable stent. It was one of the first generation device with these characteristics, and you see with a patent vessel, and 19 months later, you know, completely almost completely dissolved of the device in place. This is a nice paper that was published almost 10 years ago already, the TECO study that was conducted by Jan Goffic. More than 100 patients, and it was a randomized study between surgery and stenting. Very interesting outcome, because you see there is not a big difference between, in terms of patency rate between the two techniques, and also in terms of freedom from TLR. So this tests the concept that, especially for patients with severe comorbidities or challenging condition, also endovascular procedures with stenting seems to be very useful and safe. So in conclusion, we can affirm that the endovascular approach for common femoral artery can be considered now a valid alternative to the standard surgical approach. Obviously, we need to prepare very well the lesion, especially in terms of calcification, with a residual lumen greater than 30%. IVL atherectomy are more than welcome to help us in the preparation of the vessel, and then to complete the procedure with DCB or stenting. We have to avoid the plain balloon angioplasty, because we know results are not very good. Something that we have to keep in mind is combined treatment or hybrid procedure, surgery plus endo, that in a complex situation should be also very interesting. And obviously, more comparative studies are needed in the near future. Thank you for your attention.